Enteric fevers, typhoid and paratyphoid. Typhoid and paratyphoid fevers, which are transmitted by the fecal-oral route, are important causes of fever in South Asia, Sub-Saharan Africa and Latin America. Elsewhere, they are relatively rare. Enteric fevers are caused by infection with Salmonella enterica serotypes typhi and paratyphi A, B and C, but invasive disease is occasionally observed with non-typhoidal Salmonella spp. After a few days of bacteremia, the bacilli localize, mainly in the lymphoid tissue of the small intestine, resulting in typical lesions in the Peyer's patches and follicles. These swell at first, then ulcerate and usually heal. After clinical recovery, about 5% of patients become chronic carriers, i.e. continue to excrete the bacteria after 1 year. The bacilli may live in the gallbladder for months or years and pass intermittently in the stool and, less commonly, in the urine. Clinical features. Typhoid fever. Clinical features are outlined in box 13.44. The incubation period is typically about 10 to 14 days but can be longer, and the onset may be insidious. The temperature rises in a stepladder fashion for 4 or 5 days with malaise, increasing headache, drowsiness and aching in the limbs. Constipation may be caused by swelling of lymphoid tissue around the ileocecal junction, although in children diarrhea and vomiting may be prominent early in the illness. The pulse is often slower than would be expected from the height of the temperature, i.e. a relative bradycardia. Image 13.44. Clinical features of typhoid fever. First week. Fever. Headache. Myalgia. Relative bradycardia. Constipation. Diarrhea and vomiting in children. End of first week. Rose spots on trunk. Splenomegaly. Cough. Abdominal distension. Diarrhea. End of second week. Delirium, complications, then coma and death if untreated. At the end of the first week, a rash may appear on the upper abdomen and on the back is sparse, slightly raised, rose-red spots, which fade on pressure. Cough and epistaxis occur. Around the 7th-10th day, the spleen becomes palpable. Constipation is followed by diarrhea and abdominal distension with tenderness. Bronchitis and delirium may develop. If untreated, by the end of the second week the patient may be profoundly ill. Paratyphoid fever. The course tends to be shorter than that of typhoid fever and the onset is often more abrupt, with acute enteritis. The rash may be more abundant and the intestinal complications less frequent. Complications. These are given in box 13.45. Hemorrhage from, or a perforation of, the ulcerated Peyer's patches may occur at the end of the second week or during the third week of the illness. A drop in temperature to normal or subnormal levels may be falsely reassuring in patients with intestinal hemorrhage. Additional complications may involve almost any viscous or system because of the bacteremia present during the first week. Bone and joint infection is common in children with sickle cell disease. Image 13.45. Complications of typhoid fever. Bowel, perforation, hemorrhage, septic foci, bone and joint infection, meningitis, cholecystitis, toxic phenomena, myocarditis, nephritis, chronic carriage, persistent gallbladder carriage. Investigations. In the first week, diagnosis may be difficult because, in this invasive stage with bacteremia, the symptoms are those of a generalized infection without localizing features. Typically, there is a leukopenia. Blood culture establishes the diagnosis and multiple cultures increase the yield. Stool cultures are often positive in the second and third weeks. The Weevil test detects antibodies to the O and H antigens but is not specific. Management. Antibiotic therapy must be guided by in vitro sensitivity testing. Chloramphenicol 500 mg 4 times daily, ampicillin 750 mg 4 times daily, and cotrimoxazole 960 mg PO or IV twice daily, are losing their effect due to resistance in many areas of the world, especially in South and Southeast Asia. Fluoroquinolones are the drugs of choice, e.g. ciprofloxacin 500 mg twice daily, if nalidixic acid screening predicts susceptibility, but resistance is common, especially in South Asia and also in the UK. Extended-spectrum cephalosporins, ceftriaxone and cefotaxime, are useful alternatives but have a slightly increased treatment failure rate. Azithromycin 500 mg once daily is an alternative when fluoroquinolone resistance is present but has not been validated in severe disease. Treatment should be continued for 14 days. Extensively drug-resistant XDR, typhoid has been causing an ongoing outbreak in Pakistan since 2016 and azithromycin is the only currently reliable oral therapy. Pyrexia may persist for up to 5 days after the start of specific therapy. Even with effective chemotherapy, there is still a danger of complications, recrudescence of the disease and the development of a carrier state. Chronic carriers were formerly treated for 4 weeks with ciprofloxacin but may require an alternative agent and duration, as guided by antimicrobial sensitivity testing. Cholecystectomy may be necessary. Prevention. Improved sanitation and living conditions reduce the incidence of typhoid. Travelers to countries where enteric infections are endemic should receive typhoid vaccination. In young children, a tetanus conjugate vaccine containing the polysaccharide conjugated to tetanus toxoid has over 80% efficacy and is superior to older inactivated injectable or